So the lower pano will tell whether it is easy or tough. Premolar to premolar it looks okay. In the root of 6 there is bone loss here. Okay, this is the mental foramen, right? This is the mental foramen. You see the cross section. You start from the 4, 5. So we can expect a lot of bleeding tomorrow. So bone bags better to keep in hand. We have advised mouthwash, right?
Yes.
So tomorrow also before starting early, 5 minutes concentrated mouthwash. Food looks okay, but the thing is, lately there is
bone loss.
Severe bone loss. Even if we do some earlier restrictive here, we can use this bone, but we don't know whether this is the anterior loop. Okay. So what we can do is we can tilt it anteriorly, right? So this is the mental foramen. It is a thin canal. So tilt initially. If we are tilting this much angle, we can tilt from 5 also. You know, when we tilt it, we avoid this. So almost it is not from 4, it is slightly distal to 4. Between 4 and 5 we can. So here also you can see labally there is severe bone loss, but lingually the shelf is higher. So after rehabilitation you can see the slope. And we will plan one implant in the molar area. We are planning for a screw retain, right?
Yes.
So molar is very exactly in the interdental area. Yeah, we have some good bone. Interdental area. This is the canal. Up to canal it is 10. So we may have to use a 8 mm implant. This is more than enough. But the bone quality is good. So no need for us to go lingually also. You can go lingually or you can place straight or you can place parallel to the buccal plate. And that is also one option, sir. So 4.2 into 8. You will see a 360-degree bone. See here there is a defect is there. That is a distal, right? That is okay. So we will see the left molar. This is the distal root, right?
Yes. Interdental.
It is almost similar to the right hand side. 8 mm implant we can place. Bone quality is excellent, so a short implant will do. Okay. The only thing is we have to check the bone loss distally. In this buccal view it looks good, but what about the mesodistal? See the bone loss. Okay. So distal support, one implant is enough. Since we are planning with the bar, only one implant in molar area is enough. Anteriorly 3 implant is enough. So totally all on 4, 5. So this is 5. This is 3, 5. Okay, the foramen is slightly between second premolar and molar. Right? Here it is in the second premolar, but here it is slightly distant to the second premolar. So we will check the first premolar. See the problem, the challenge is lingually the bone is okay, but buccally there is severe bone defect. You cannot do alveoplasty here, right? Okay, you can do alveoplasty. Do alveoplasty of 3 mm. But anyhow, at the end, you won't get a flat surface. You will get a sloping one, like we can place implant close to the lingual side. One thread may be getting exposed, but that is okay. We can submerge implant. We can over insert the implant. We will see. we will tilt from the 4, between 4 and 5. We can place a 13 mm implant vertically close to the lingual. This is buccal view. You see that this is the mental foramen and this is coming here. It is circular. Okay. So anteriorly you have the option of placing 2 implant close to midline, or placing only 1 implant also is okay. Anteriorly it is good. Because they already been fallen off. So anteriorly we can place 2 or 1ness also internally. Yes. Okay. So basically it is like a all-on-4 tilted, but with additional support in molar to avoid cantilever. Since we are placing implant in the molar area, we can remove one anterior. So it becomes here one. Okay, so we don't know how the lines.
Artifact.
You can see Aarti. Right? What is these 2 lines now? Like Walbury. These are arteries. Posterior superior,
Inferior. Anti-middle superior.
No, they are arteries inside the sinus.
Okay.
When we do zygomono, bleeding will come from the lateral wall. So we are not going to touch those arteries. Nothing to do. They run inside the sinus, along the bone. Tell me tomorrow what is the name. They will bleed like anything during lateral sinus lift or during zygoma especially.
One time
We have seen in CLDC also, it will bleed like anything. Pain is very much sharp. That is why he is having the good nasal prominence. So while flap elevation we may have difficulty here. So we have to elevate fully, exposing the nasal floor, lateral nasal wall. Concha. No, you don't need to expose concha. So this is the buttress area. The sinus has come till here, right? The buttress is not very great. Anteriorly we have to place 2 implant. So this is the anterior edge of the nasal spine. This is the nasopalatal canal. So there is a good volume of bone in front. That is a good sign actually. If you place implant in the midline, we can engage in this nasal bone also. We'll first check that. Okay, either you can place like this, right? Or we can place labially. But we will see the 1-2-2 area little.
Since the canal is very wide, we are not placing inside the canal.
We can place the implant inside the canal, but it is 6 mm. We need a 6 mm implant. Otherwise, it won't get stability, right? So placing 6 mm is not. So we are going lateral. Very. See the labial concavity in lateral incisor. Right? The bone quality is excellent, even though it is only 12 mm. So maybe 3.75 into 1.5 we can place. Entirely palatal approach. So we'll see the 360 degree. Okay. We'll add one more on the 2-2 area. Almost the same, 11.5 mm we can place. See the tooth is completely out of the bony housing. See the root apex is close to the nasal floor. Right? Something different here it is. See the bone is here, but the tooth is completely outside. The main challenge is the pterygoid. Sinus has been pneumatized till the pterygoid. And another problem is the pterygoid does not come properly here. You can see some pterygoid good bone is there. Maybe 4.2 into 13 we can place. Definitely we have to place pterygoid because we cannot place anything in the 6, 7, even 5. So if we cannot place implant in pterygoid, that means that then we need zygoma. So this is 5. See 5, there is no bone, right? Except the small palatal bone. If at all we are not getting any pterygoid, we may have to use this one. Very less.
Multi-unit basal.
Yes, multi-unit compressor.
So the bone is very thin.
Yes. The implant is tapered, no? So no issues. Even if it is exposed here, actually, we are getting support from the palatal bone and the nasal floor. Of course, this is not our plan A. This is plan B or C. We are checking from 4. Even the sinus pneumatitis is still the 4, right? This is along the mesial socket of 4. Okay. You can see now here. This is the buttress is coming here now. And we will tilt slightly anteriorly towards the lateral, this area.
Nose.
Yeah, mesomaxillary buttress area. Here some good bone is there. Not very great. Lengthwise it is not great, but quality wise it is good. See the value 900, 1200. Even though we will be placing a very short implant, 1.5, 4.2, 1.3, that is more than enough. Maybe we can tilt the crustal part slightly distally from 5 also, right? But there is no big advantage in tilting it. Anyway, we will bend it. We will keep it from 4. Okay. So that we will keep 5 free. If anything happens, if we cannot place any pterygoid. I think pterygoid bone is there, but the sinus, it is expanding more distally. If we take another series, we will come. The only problem is post extraction there will be bleeding. So our plan will be before so all teeth are mobile, they have great mobility. I thought of removing only the molars and place 2 pterygoid, then we can come to the thing. The difficulty which we will face now, while doing lower, the upper will be very much mobile and they will give trouble during surgery, right? Otherwise, what we can do, we can finish the upper first. We can finish the upper using vestibulum retractor, then we can do it. Otherwise, wherever it is more mobile, we can give just infiltration there and plug it out. Tomorrow we will finish lower, upper first. So we will see the 7 or O plus. You can see the sinus mucosal, right? Can you see the sinus mucosal due to perio only? Can you see?
Yes, sir.
The sinus is clear here, but here there is a sinus mucosal is there, but it is none of our concern. 5. This is 4. 4 also. The sinus is expanding. We will tilt it anteriorly. We are getting good bone here. From palatal to buccal approach in place. Nice. Pterygomaxillary buttress. See, the thing is, pterygomaxillary buttress is from here to almost 5 to 6 mm. This band. For some patient, this band is very less, only 2 mm or 3 mm. For some patient, it will be 7 mm, 8 mm, even 1 centimeter. Also, the zygomatic maxillary buttress will be there. So, if you see this side, this patient is having a little bit wider buttress than on the right side. Maybe because of the sinus expansion is more on the right side than on the left side. So that is why even if you are tilting mildly, you are getting a good bone. You can tilt more anterior also, you will get bone. Okay. So our target area is from this corner to this corner. if the sinus is expanding till here, then we have no other option. We have to target here. But for this patient here also there is good bone. So that is why we are not tilting very much. Okay, so we are tilting, we are reducing our tilting. If you place straight, you will enter the sinus. But the moment you tilt 10 degree, you are getting good bone. But right side, you are in good bone. Now see, no, here also the buttress is little wide. The tip is here only, not here. So another option is you can tilt till this corner also. We will see this. Here also you can tilt. Can you see? We have the freedom of 6 to 7 mm from this corner, from this lateral, this corner to here. So this will help during surgery. So I will keep the drill. I will mark with pencil from here or from here. So during CBC analysis we can plan this. If the sinus is coming till here, then no, we have no other option. We have to drill here. If the sinus is expanding till here, then we have to push this entire implant mesially, like this. We will start the drilling from canine only. Have you seen? Some implant we start from canine only, because till canine, crustally also sinus is expanded, and in the basal level also it is expanded. So what is the sinus expansion? In both levels we have to check. If this sinus is expanded till here, then we have to shift the position to more anterior. If this patient could have come 10 months back, we could have got some more good bone. All the alveolar bone has gone, complete. 100% there is no alveolar bone now. So after opening, we don't have to do alveoplasty. We have to just smoothening and just flattening the surface. Maybe in lower, we may have to remove the lingual shelf. Lingual shelf is higher. Whenever the lingual shelf is higher and buccal shelf is very much down, they will bleed like anything. So we will see.
Inwardly there is more.
I don't know. Have you seen Kavita? No? During BLDC. Many patients, when the lingual bone is very much higher, but the buccal bone is very much down, there is a slope, there will be a lot of bleeding.